I want to welcome everyone to the University of Winnipeg, which is situated on Treaty 1 land in the heart of the Métis Nation. My name is Claire Reid. I'm the director of the Masters in Development Practice program, and we're really pleased to be here today together with the CN Indigenous Resource Centre hosting Dr. Kettner in this, the final of a 4-part lecture series on public health in the 21st century. And today's talk will focus on the politics and ethics of public health. So I think some of the questions actually from the last series were really pointing towards this one, so I think we'll have a lot of great discussion at the end as well. So after Dr. Kettner's presentation, there will be a chance for questions and discussion, and just to let everyone know that we are recording the talk as well as we recorded the previous 3, and they will all be up on the MDP website. So if you were unable to attend the earlier sessions, you can go and check them out there once they're up. Thanks again to all of those who put in a lot of work organizing this, and thank you very much, Dr. Kettner. So Dr. Kettner is a senior fellow and visiting instructor and visiting scholar with the Masters in Development Practice program, coming up 2 years now. And he has been a public health medical professional for more than 2 decades, based at the University of Manitoba's Faculty of Medicine and working for the Province of Manitoba Department of Health. And after 10 years was working as the Regional Medical Officer of Health in northern, rural, and urban settings, he was recruited to be Manitoba's Chief Medical Officer of Health, which he did for 12 years. He is a very busy man, so I'm going to just detail some of the things that he's involved in now, just to give you a sense of his vast experience and knowledge. He's the medical director of the International Centre for Infectious Diseases, a scientific lead for the National Collaborating Centre for Infectious Diseases, director of the Masters of Public Health program at the U of M, and a health mentor for Grand Challenges Canada in their international research project. He's president of the Public Health Physicians of Canada and a director of Canadian Public Health Association. He's also a member of the University of Winnipeg's newly formed Healthy Campus Advisory Committee, and as I said, a senior fellow with the MDP teaching on public health and sustainable development. So again, this is the last of our series, so thank you very much to those of you. I recognize several faces from all of the series. Thank you so much for coming, and thanks to those of you who came this evening. So without further ado, Dr. Kettner.
Thank you, Claire, and good evening, everybody. Thank you for coming. Quick question for you. How many of you are here for the first of the 4 lectures, haven't been to any? Welcome. And how many here have been to all 3 of them so far? I have. Yeah. I think there should be a prize for those who have come for all 4. Well, that's already in the books, Tom. So I wasn't sure how many people would be here that hadn't attended previous ones, so I'm going to do a little bit of a quick summary of the first 3 talks, but I think for those of you who were at one or more of those, I hope that you won't find it boring, and maybe it will be a little bit of an emphasis or review for you. So I'm going to try and get through this in about 45 minutes, and I may have to go a little bit quickly through some parts of it, because as usual I have too many slides, because this is a big topic, and I'm not very good at paring things down. But I really hope that there's time. In fact, I will stop at 45 minutes because I'm going to be warned enough to do that, so that there's some time for discussion and questions. Because really the topic of this evening is not one of hard science and hard facts. It's really one of opinion, judgment, gray areas when we talk about principles, ethics, policy, law. So I hope that there'll be a chance to have some dialogue about that. So this is the 4th talk, Principles, Power, and Public Policy, the Peculiar Ethics and Politics of Public Health. Okay, so the first question we asked was, what is public health? Who needs it? And the World Health Organization defined it along with primary care about 40 years ago. And it really deals with the basic needs for health. So it includes at least these things, which you're all familiar with: maternal and child care, immunization. Those are the things we usually think about when we think about public health. But even in that time, it addressed other issues that are basic needs for health: food, housing, education, public works. So public health goes beyond the health system, as we will discuss again a little bit today. And I try to help people remember what public health is by thinking of these words that start with P. If it isn't prevention, it's not public health. It's a population-based practice, as opposed to individual encounters in primary care. It has a perspective that's broad and deep and must think about the future of generations. It actually doesn't do much work by itself. It relies on partnership with many to really carry out the day-to-day activities that result in health. And of course, there is power in public health, and we will talk a bit about that this evening when we talk about public health law. So public health was needed 100 years ago in Winnipeg when the pandemic struck. In fact, the Department of Health was created. The Department of Health and National Welfare actually in Canada was created because of the events of the Spanish flu. And we had some data from that which showed that not only was it a huge cause of mortality, 1% of the population died approximately, but there were variations depending on where you lived, and in Winnipeg, North Enders died at about 50% higher than the rate of South Enders. Well, a century later, the pandemic, of course, resulted in much less death, but we had a similar observation about differentials in outcomes. And at the height of the pandemic, when our intensive care units were full, 1/2 of the patients in the intensive care units were of Aboriginal ancestry, highly overrepresented. So, bottom line, I think public health we recognize as something we all need, but some of us need it quite a bit more than others. In the second talk, we looked at Manitoba's picture, using information from the report on the health of Manitobans that was released 3 years ago. And again, just a quick review of that. In terms of causes of death that result in premature death, or as we calculated, potential years of life lost, in Manitoba, cancer and heart disease and other chronic diseases are responsible for about half of the potential years of life lost. Injury, about a quarter. So half of those are unintentional injuries, mostly motor vehicle crashes and falls. But suicide, especially when we look at age of death, is actually responsible for 7% of potential years of life lost in Manitoba, and homicide 3%. Conditions related to birth, prematurity, etc. make up about 10%. So it helps put into perspective what are the big health outcome issues. But of course, those are average statistics for the whole province. And as is often the case, if we look at things like life expectancy across the gradient of urban areas on your right and rural areas on your left, based on census data of income quintile, we see the typical gradient from the poorest neighborhoods to the wealthiest of approximately 10-year difference in life expectancy for men, somewhat different, somewhat less differential for women, and similarly in the rural areas. And if we look at the another important measure to compare health status, infant mortality, we see that the rates of infant mortality vary threefold between neighborhoods of low income and neighborhoods of high income. So I summarized our big problems in Manitoba as, first of all, that recognition of significant inequalities in health status by race, income, geography. I didn't mention in those last slides that much of those differentials are the same when we compare Aboriginal with non-Aboriginal populations. Some important observations that I referred to were the readiness to learn of our children. 1 in 4 children entering grade 1 do not pass an indicator test in all categories of physical, emotional, and intellectual readiness. And when you look at children in the lower income areas or amongst Aboriginal populations, that rate is 1 in 2. And we know what the long-term impacts are of that lack of readiness to learn because of inadequate early child development and many other factors. We reviewed that about 1 in 4 Manitobans are considered to be drinking alcohol beyond recommended guidelines. About 1 in 5 smoke. That's higher for, again, our Aboriginal population, where more than 50% smoke. We know that, we reviewed also that more than half of our adult population is overweight and is inactive. A third of our children are overweight. And we looked at some data around chronic diseases and unintentional injuries and mental health and suicide, which I already mentioned. The recommendations, just to look at a few of them from that report, were first of all that the government of Manitoba should adopt 2 overarching goals in their strategies. One is to improve the health of Manitobans, and the other to reduce inequalities of health amongst Manitobans. And of course, in part of that is paying attention to the publicly funded health system, because approaching now 50% of the tax revenue expenditures in the provincial government for health care, it is evident that there needs to be a balance between expenditures in health care and expenditures to address these other determinants of health and reduce health inequalities. And that these strategies need to focus on outcomes, the behaviors and activities that we know result in these outcomes, but also, importantly, the determinants of health which are associated with these behaviors that vary according to education, income, race, geography of residence, etc. And the approaches that were recommended were, first of all, to look at all government policies with respect to the impact that they have on health and health inequalities, to increase engagement of organizations and citizens in our planning and looking at opportunities for prevention, to strengthen the vital role of families and communities, particularly in promoting the health of our children, to promote more equitable distribution of the determinants of health, and to improve the conditions of everyday living, and fifth, to enhance preventive programs, and particularly more outreach for those who do not always access services as needed. The third talk was about, can we prevent the threats that we do not see? And this is a close-up of the tubercle bacillus, the cause of tuberculosis. But we looked at the fact that even before that was known or seen, in the last 150 years, the mortality from tuberculosis fell dramatically over that time period, even though it wasn't until halfway through the drop that we discovered the tubercle bacillus, and that drugs were not available until the late 40s and early 50s. So what did this tell us? It told us that even when we do not know or see a threat, that with improvements in living conditions, in nutrition, in sanitation, in the resilience of the population, that our health status and ability to withstand whether it's infection or other diseases is significantly improved. And yet, when we look today at Canadian statistics, we find that we have not been able to beat this scourge of tuberculosis. And this shows in blue the rate of tuberculosis for Canadian-born Aboriginals compared to our second highest rate, which are foreign-born. But what you can hardly see at the bottom are Canadian-born non-Aboriginals, because the rates in Canada for Aboriginal people are about 30 times that of non-Aboriginals, and for Inuit approaching 600 times the rate. Now, again, could spend the rest of the talk about what are the issues and conditions that are relevant to this difficulty in addressing and solving the problem of tuberculosis, and maybe we can talk about that in the discussion period. But part of it is what we see not just within countries, but between countries. So, a typical look at the relationship here between life expectancy and the average income per person of a country. A very steep rising curve and then a flattening out, but quite a convincing relationship. We talked about another problem that many of us do not see or know, which is climate change. And this image, I thought, was quite important to understand the distribution not only of sometimes the source of our problems, but also the impact of our problems. And I think this captures a lot of what we're going to talk about next, which is politics, policy, ethics. Because what we see here is a depiction by image of where cumulative emissions of greenhouse gases come from in the world. And I'll just make the comparison of North America here and Africa. And the World Health Organization estimates of what the per capita mortality increase will be from climate change, based on some predictions of impact on infectious diseases and other conditions of drought and flooding. And here we see minimal impact in North America, significant impact in Africa. One of the most interesting type of data that's coming out that we looked at is not only this difference between rich countries and poor countries, but looking at countries where the distribution of income and wealth within the country is wide or narrow. And this is an index that looked at many things: life expectancy, literacy, infant mortality, homicide, imprisonment, teenage birth, measures of trust, obesity, mental illness, social mobility, and looking at the range of income and wealth from between the upper quintile and the lowest quintile, look at countries where that income inequality was high, and in those countries the index of health and social problems was highest, implying, if not proving, that gradients within countries in big gaps in wealth, privilege, and power have an impact on the health status of the whole population, not just those who are in the poorest or least privileged parts. So, how long did that take? That was 15 minutes? Okay, perfect. So now let's talk about today's topic. So let's define a couple of terms. What do I mean by politics in this context? Well, two terms from our Canadian Oxford Dictionary relate the two things I think I'm thinking of when I talk about this. One is the business of government. How it works, and particularly how it works within the context of public health. And the other is more the principles, the ideology, the sets of ideas that relate to distributions or exercising of authority and power. So I'm not going to be too ideological this evening, but I am going to try to lay out what I think are some of the issues and problems associated with public health in the context of a complex society like we live in Canada. Now, I use the word the peculiar ethics. There's different meanings of the word peculiar. Most of us think of strange or odd or unusual. That's not exactly what I was thinking of. I was thinking more of quite particular or special to public health, although I think there are some things that are maybe a little different about the ethics of public health that I hope to bring out in the discussion. So, Lawrence Gostin, who's probably done most of the writing about public health law from Georgetown University in the USA, talked about ethics in public health in these three ways: ethics in public health, ethics of public health, and ethics for public health. The most important and first point is ethics in public health. And I think this is the key of pretty much everything else we're going to be thinking about for the rest of this talk, which is that trade-off between collective good and individual interest or individual freedom. Because the public health perspective is a population perspective. It is a collective perspective. It is a social perspective. And that's what really distinguishes it from other parts of the health care system, which is individual encounters in care. But it also distinguishes it, I think, in many ways from maybe some of the other principles or ethics or values that we have in society with regard to individual rights and freedoms. The second is the ethics of public health. And this relates to the relationship between society and the population on the one hand, and individuals, professionals, in some cases, civil servants who may not be professionals, but who work in the public health domain. And it's that relationship of trust that must be established if there's going to be any effectiveness in public health practice at any level. You could say that's the same for individual health care, the trust between the patient and the physician. When I was Chief Public Health Officer, I would say when negotiating for a pay rise that I had 1.2 million patients and should be recognized, that should be recognized as such. However, when I was asked to do any work, I would say I don't really have any patients at all. That's up to everyone else to look after. So you can look at this, I guess, from different perspectives. But the relationship, I think, between the public health doctor and the population must be based on trust. And the only way I know to do that is to always tell the truth. And we can come back to that a little bit maybe in the discussion. The challenge working in government or in any public domain is how much of the truth are you going to tell at any one time? Because truth is a matter of opinion often, and of course it was my job to be sure that whatever I did say, that I could support it, that it was evidence-based, that I could sleep at night, and that the public would continue to have trust and confidence in the information that they were being given. The third ethic is the ethic for public health. And this has to do with recognizing the values of the community in which you work, but also the value of healthy communities. And here's where I think there could be some debate about this, but Gostin argued that the particular emphasis on the ethics for public health is particular emphasis the particular emphasis is on that of those most disadvantaged and those most oppressed, was the language that he used. And I think this is a feature of public health ethics, that there has always historically been, and I think there continues to be today, an emphasis of public health practice to focus on those and those sections of society who are most in need of support and assistance for purposes of their health. So, what are the core values? Collective responsibility for health and well-being, population focus, community involvement and civic responsibility, a prevention orientation, and that last point again, social justice. When we look at the levels of engagement that public health has with the population, I like to think of 5 levels, all starting with the letter E, so that my students can remember these things. Mostly it's so that I can remember them. Starting at the most basic level, which is education, just providing information. So, smoking causes lung cancer, it's a fact. What people do with that information is up to them. The next level of public health engagement is actually to encourage people to change their behaviors. So, we would say not only that smoking causes lung cancer, but people should quit or not start. That often isn't enough either, so the next level is to entice people. And public health and the laws of society can be brought to bear on increasing the price of tobacco through taxation, with some evidence that at least in the short term, sales of tobacco products go down. But it starts to use more reward and punishment methods. And there's so many other things we could talk about that taxation could be used to either support or discourage. And of course, partly that's an enforcement mode, but a higher level of enforcement is actually preventing people from smoking. And of course, that has been an increasingly developed method of public health, particularly on the principle that smoking which affects others, as opposed to enforcement so that people themselves will be healthy, but because of our understanding of the risks of secondhand smoke, it created the possibility for making smoking in public places, in restaurants, etc., enforceably illegal. And of course, that had other impacts on the total environment. In other words, the social environment, what we would call denormalization of practice. So if you don't see people smoking, or if you don't see cigarettes in the store because they're hidden behind curtains, I don't think there's a lot of evidence that that's been effective in getting people not to buy cigarettes once they've come into the store. But certainly the effect of not having smoking as visible in society has probably had quite an important effect. So the ethical decision for a public health practitioner is how to do the most good and the least harm with the least interference of freedom in the long run at the least cost, using the best evidence. That is not easy to do. Physicians are actually expected to act ethically, and we have a code of ethics of the Manitoba College of Physicians and Surgeons of Manitoba, which interestingly makes it quite clear that the role of physicians is to pay attention to public health. And you'll see that it requires the recognition that community, society, and environment are important factors in the health of individual patients, that it's a responsibility, it's an ethical responsibility of physicians to accept a share of the profession's responsibility to society, to provide fair access to health care. And here's a point that I probably should have made at the very beginning of the talk, which is that it's a requirement of physicians, or a responsibility, I should say, to give the generally held opinions. I don't know if you can read this at the bottom. The generally held opinions of the profession when interpreting scientific knowledge to the public, and when presenting an opinion that is contrary to the generally held opinion of the profession, to so indicate. Now, I say I should have said this right at the beginning of the talk. I do not believe that so far I have said anything that is contrary to the generally held opinion of the profession. And I don't plan to this evening either. But if I do, I will try to remember to tell you that I have. Okay, some interesting history. So, Hippocrates, we all heard about Hippocrates and the Hippocratic Oath, about ethics in terms of the individual patient. Hippocrates was actually much more interested than we think in public health, and he talked about how people live, how they eat, how they exercise, etc. But he also talked about how people live and are organized in society. And he made this observation of a part of Asia where he talked about the laws of that race. And he actually talked about the conditions in which people were living, and that they were not their own masters nor independent, but the slaves of others. And he described quite poignantly how men would die far from their children and their wives and friends, fighting in wars that led to the aggrandizement of their masters, whilst the fruits that they reap are dangers and death. So politics, ethics, principles, public health, happening 2,500 years ago. This is a German physician named Rudolph Virchow, and he lived during so many important changes in public health in the 19th century. He was a remarkable physician who's actually very well known to medical students and physicians because of many pathological conditions that he has his name after. But what people don't know as much about him is that he's really considered the father of social medicine. In fact, he made the statement, and this is a quotation from him, that medicine is a social science. In fact, he said that politics is nothing else but medicine on a large scale. Now, I have to say, this is probably a moment for me to say that this might not be the generally held opinion of physicians. I'm not sure that I hold this myself. This is a fairly broad sweep of functions and responsibilities for physicians. But he did say that physicians are the natural attorneys of the poor, and that social problems fall to a large extent within their jurisdiction. And an interesting story about him is that he was asked to work on an outbreak of typhus at the time. And he concluded that this outbreak could not be solved by treating individual patients with drugs or with minor changes in food, housing, or clothing laws, but only through radical action. And here's where he went a little further than Hippocrates, to promote the advancement of an entire population, which could only be achieved by, and he talked about democracy, education, freedom, and prosperity. So, again, he didn't use the term determinants of health, he didn't use the term sustainable development, but if you read more of what he wrote, these were many of the basic principles and ideas. At this time, he was actually employed by the government as a public health physician, and after submitting this report, he was fired. But he was rehired, I think, within a year or so. So I guess maybe he was also at that time representing a view that was not considered the norm of the physicians of his day. Well, let's look at some public health law and see how they reflect the principles and ethics of public health. The first Public Health Act, at least in the developed world, is considered to have happened in England in 1848. And in that act was the creation of local boards of health, which had a set of responsibilities. They did have an officer of health, probably the first official medical officers of health, who had to be a qualified doctor. And their main responsibilities were to manage the sewers, street cleaning. Of course, street cleaning in those days was quite a bit different than it is now, probably properly put in here between sewers and public lavatories in this list. But they were also responsible for slaughterhouses, street paving. Maybe if we gave street paving to public health here in Winnipeg on an injury prevention program, we'd have fewer potholes. Pleasure grounds, which I actually am not sure what those were, but I'm pretty sure they were just parks. Water supply, only if it was not provided by a private water service, and they were in charge of burials. So let's go fast forward to the latest version of the Manitoba Public Health Act, which, by the way, has many regulations related to some of these things, but not all of them. And let's look at some of the powers that are given to public health officials. So the most important first point of power is to get information that's needed to assess the health of a population or to assess a public health threat. And this power, and I should say this Public Health Act, which came into force in 2009, was the first revision of the Act for about 40 years, and a lot of work was gone into it to bring it up to date and to reflect much of the, that's a half hour? Perfect. To reflect much of the thoughts and in some cases decisions of inquiries and commissions that happened because of events in public health in Canada. One of them was the Creever inquiry after the transmission of hepatitis C and HIV through blood, which observed in the inquiry that there were people in public health who were concerned about the risk but had not been given the full information or the full freedom even to disclose that information to the public. With the SARS outbreak and some other events, the conclusions have always been the same, which is that public health doctors, public health practitioners need to be able to speak openly and directly, and they need to get the information they need in order for those reports to be valid. So the Manitoba Act actually was developed after many of those events had happened, and I think reflects quite well the current thinking about the ethics and power of public health. So let's look at a few other interesting things about it. With regard to that information, it comes in clash, in a way, with the Personal Health Information Act, which says that no health information should be shared unless the consent is given of the individual whose health information this is. And there's an exception in the Personal Health Information Act that says that that permission, that consent is not needed if the information is needed to prevent or lessen a serious and immediate threat to the health or safety of the individual or another individual, or in general, public health or public safety. So that power is given to the public health officer to get information and can ask for any information needed to make that assessment. On the other side, which is reporting to the public, there are two aspects of the Manitoba Public Health Act. One is a requirement to report at least every 5 years on health status of the population. But the other is that a report can be issued at any time on any matter of public health. And the only requirement with respect to the minister is to consult with the minister about the content of that report, but not to take direction from the minister, whether it's the 5-yearly report or any other report. So there's an autonomy related to the medical officer who can issue a public health advisory describing the nature of a threat, steps people should take, and any other information. There's more than advisory, there's action that a medical officer of health can take to stop a health hazard. However, the principle is that it should be the least action necessary that is necessary to deal with the threat. And if we look at the kinds of measures that a public health officer can take, you can see the potential power. For example, the public health officer can issue directions to a regional health authority, health corporation, to do all these things. It can order the owner, occupant, or person who appears to be in charge of any place to deliver up possession for the minister as a temporary isolation or quarantine facility. It can order a public place or premise to be closed, and it can order persons not to assemble in public gathering in a specified area. Now here's where a very interesting observation is made about the relationship, I think, between public health practice and political decision making. Because all of those powers that I just read are not absolute powers for the medical officer of health. In fact, minister's approval is required for all of those. So the significance of that, I think, is that for a decision which causes big disruption to society, that it's the job of the chief public health officer to give advice, to make recommendation, but that it is really the elected representative of the people to weigh up the issues, the values, and make a decision before disruptive action is taken. So that's the relationship between the public health officer and the government. Now let's look at the relationship between the public health officer and the citizens, because there's quite a lot of power that a medical officer of health has to order people to take protective measures against a communicable disease, to be immunized, or to take other preventive measures, or to refrain from an activity or employment if that could put others at risk. So, how much power is that? Well, the truth is that in the Public Health Act of Manitoba, as is true in many other places, nobody can be forced to get an immunization or to accept any medical treatment. Considered an invasion of privacy. So there's a limitation at that level as well. Having said that, if deemed necessary, people can be excluded from work or from school if they have chosen not to get a vaccine for measles when there's an outbreak, etc. Now, we can look at the federal act as well, and here's where some interesting things are brought out. Because one of the issues right now of importance in Canada is the relationship between the federal government and the provincial government when it comes to health, healthcare, and public health. So when the Federal Public Health Agency was created, and by this act, The Act had in it the ability of, by regulation, for the agency and its chief public health officer to, for example, collect, analyze, interpret information from the provinces. The federal government has not enacted any regulations along these lines. So at this point in time, the federal government does not have any power to obtain that information from the provinces. Despite the fact that it is part of the international health regulation that the federal government is the focal point to report to the World Health Organization if, for example, there's a public health emergency of international concern, which of course we would observe in the provincial domains through our surveillance systems. So right now, a lot of what happens between the federal government and the provincial governments is based on agreement, voluntary cooperation, but the Federal Public Health Agency does not have the same kind of powers as I've described, for example, in Manitoba's Provincial Public Health Act. Despite the fact that if you look at the Department of Health Act, the federal minister has actually many powers, duties, and functions related to public health. Promotion and preservation of physical, mental, and social well-being of Canadians, protection of Canadians, investigation and research into public health, establishing safety standards for consumer products and workplace products, transportation, health, obviously looking after employees of the government, and also issues related to international public health. Another responsibility is information relating to public health, and of course one of the controversies of the last period has been making the long-form census non-required, to some extent reducing the reliability and representativeness of that data, and therefore making it more difficult to get the kind of relationship information between social conditions, economic conditions, and health outcomes. Having said that, it's again a matter of political judgment as to balance many things in terms of collective good and individual freedom. And of course, another role of the federal government is to cooperate with provincial authorities with a view to coordinating efforts for preserving and improving public health. So, I'm going to name right now 10 current issues of policy and ethics in Canada that I think are representative of a number of ethical, legal, and matters of principle and policy in public health. So I've talked quite a bit about the first one, which I still think is the most important. In Canada, we have very good average health statistics, but tremendous disparities, as I have mentioned over and over again in these talks. How are we going to get to solve these problems? Well, I think that the other 9 here are relevant. There is a very important distinction between looking at health issues and social issues as health or crime issues. So, drugs, prostitution, issues related to mental health and crime. These are important examples where these disparities come out in realities in everyday life and health statistics. This is clearly a political issue. It's a matter of policy. It's a matter of ideology. And the public health view in general is to try to look at these issues as health problems. So when we look at harm reduction versus abstinence of things like injection drugs, the safe injection site that's been established in Vancouver, which has run into a number of legal and political problems, is an example of taking a health view of drug addiction and the risks associated with it rather than a criminal perspective. Another important issue is personal responsibility versus social determinants, which are related to that. How much do we hold people responsible for their behaviors and actions versus the conditions that they have grown up in and that their parents have grown up in residential schools, for example? And how do we address the consequences of that from a health perspective? And again, public health tries to understand always the underlying causes and address underlying causes. The federal versus the provincial and territorial government roles in health. The biggest issue in Manitoba, probably in this regard, is the jurisdiction split for health care and other services for our First Nations, Manitobans, and other Manitobans, and the difficulties that that continues to cause, mostly for our First Nations people, but for those who try to provide services in that context. Our health system is still focused mostly on care because of the pressures of disease and injury, despite the fact that there's increasing recognition that prevention is likely going to be the long-term solution for many of those problems. Another recent issue of interest is, and these next three are all about enforcement. To what degree do we enforce the public? Whether it's wearing helmets, whether it's restricting tobacco use, or now a question on the horizon is mandatory vaccination. To what degree will we enforce our healthcare providers? We have a big concern right now about antibiotic-resistant organisms. We know that about 30% of antibiotics that are prescribed are not necessary. Do we have an ability to enforce or better monitor the practice of our physicians? I think this is an important question. And then, to what degree will we enforce private industry when it comes to things like labeling foods under nutrient profiles? All of this, and the last point I want to make, is that unlike almost every other complex industry, whether it's the airlines or the big grocery stores or Visa or the banks, we do not have a very up-to-date modern way to monitor and measure what happens in the health system and how to connect healthcare with the other information that we have about people so that we can learn better what works, what doesn't work. And there is certainly an interest in developing electronic records and monitoring, but that is coming quite slowly. Okay, so I'm out of time. But I think I've addressed the issues I wanted to, except I wanted to finish with a little bit of positive hope. Because despite many of the things I may have said, I think there is increasing recognition that public health and prevention and addressing the issues around disparities of health and the connection to social determinants of health and prevention is really taking hold throughout society and around the world. I think the Millennium Development Goals are an example of that, and you can see that many of them relate to health but also sustainable development. The UN Commission on Social Determinants of Health has put quite clearly under the World Health Organization the need to tackle the inequitable distribution of power, money, and resources. And even our, well, I shouldn't say that, that's rude, and our Ministers of Health of Canada actually endorsed a very important document a declaration on prevention and promotion, which still stands today and recognizes the importance of prevention, and here in red, to improve health and reduce health disparities, and to build and influence the physical, social, and economic conditions that will promote health and wellness. So there were many things in their declaration that you can look up, but in the end, we're going to have to figure out how to work better between government, our knowledge centers like this university, private industry, and the voluntary sector and our citizens, so that this century we will move on beyond the sanitation movement of the 19th century, beyond the advances in the science of prevention and treatment of the 20th century, and we'll figure out how to use our new knowledge, although we're still got much to learn, even what diets are healthy for us, and our technology. How will power be used and shared? What ethics, principles, and policies will guide us? Particularly, how will we balance individual rights and collective public health, whether it's within countries or between countries? Will sustainable development be our way forward, with reduction of inequalities towards peace and social justice? These are our challenges, and I, for one, feel confident that there is increasing understanding of the importance of this, many barriers, many challenges, but great hope for the future. So on that note, I will stop and take questions. Thank you.
Just ask if you do have a question, if you could please use one of the two microphones on the side of the room so we can hear you.
Kettner, great talk. You mentioned TV in all of your talks, and I worked at Health Science Center in St. Monica's Hospital in the TV lab for close to 20 years. And at some of the meetings lately, when we talk about TV and diagnostics, we mentioned that there's an outbreak of TV in certain areas of the province. But yet we're told by some public health people that it's a cluster. We call it an outbreak because that's not the proper term. So isn't public health about being honest about what something is? So that's just one question. And one opinion, and you mentioned the records, the electronic records. I'm glad you mentioned that because it's amazing in this day and age that in the labs we still have to manually fax some reports of lab results. And many times the line is busy, the fax machine is running out of paper, so I'm glad you mentioned that because it's amazing in this day and age with iPads and technology that lab results can't go to the doctors on a real-time basis.
So I'll take that second point first. That is the goal, I know, and I can speak for many in government and the e-health team that is the goal, but it is going slower than I would hope for, and I think it's important to speed that work up. The tuberculosis question. So language is important, and some of these terms are technical, and we have our own definitions for them, and some of them are terms crafted by communicators and what some people would call sometimes well, let me put it this way, the technical terms are the terms the doctors use, sometimes the terms are the spin doctor's job to figure out how to use them best. Which is not to be disrespectful, because it's important to put things out there in a way that doesn't create more harm than good. With tuberculosis, well, a cluster. A cluster usually means that we've observed some additional cases, but we don't really know how they relate. We don't know if this is part of, if we see a cluster of cancer cases somewhere, is that because there's, an exposure to something that is in that locale or in that area. before we've analyzed it. An outbreak usually implies that we know that we have an increased rate and that it is related to communicable disease between people. The truth is that with tuberculosis, especially in northern Manitoba, we have a constantly increased rate of tuberculosis. And it is difficult, without making apologies, it is difficult sometimes to know whether the cases and the contacts between them are related to that particular community or related to travel to other communities or in and out of Winnipeg. And there is a concern often about labeling a community as having an outbreak. We always, in public health, in answering questions about cases and locations, what does the public need to know in order to protect themselves and in order to understand what's going on without doing harm to a community or to an organization? Sometimes, though, the harm that's being protected is the jurisdiction that's responsible for healthcare and don't want to be embarrassed. And I think that's something that is not as justifiable. So I think that's the best I can do with that question.
I don't think this is working, so I'm just going to ignore it. I was just going to say, firstly, that was a phenomenal talk. I can really say that I really enjoyed it.
Thank you.
And it made me want to ask two different questions, but they're somewhat related. So one of the things that I was really curious to hear about tonight was, as you were elaborating on the relationship between politics and public health. And I was thinking about Dr. Virchow, who would have the ability at any time, and I apologize, I don't know if Dr. Virchow's official title.
Chief Medical Examiner.
Yeah, thank you. So Chief Medical Examiner would have the power at any time to call an inquest, whereas from what you described, it sounds like you would have to have a lot of oversight from the health minister. So I was just going to ask if you can talk about the powers that someone like Dr. Virchow would have if there's an incident of concern, and if you could personally elaborate on how in your, it was 12-year career, how you managed to kind of navigate if you had a public health concern or political oversight of any kind of public communication.
So the first question, under the Fatality Inquiry Act, the Chief Medical Examiner has quite a different position, which, as you quite rightly described, has an independent authority to issue an inquest related to any death, and that it is not subject to approval or ministerial direction. That power is not given to the Chief Medical Officer of Health in the sense of being able to call witnesses and the other powers that come with the ability to do an inquest. Having said that, there's enough room in the Public Health Act for the Chief Medical Officer to gather information and issue a report or advice on the situation. And it goes beyond just deaths. It could be any public health matter. So I don't know if that answers your question.
It leads to the second question,
Yeah.
actually, so perfectly, which is that,
Well-
I can ask it, which is what you were describing, and I was curious because you haven't spoken directly about your experience, which is what interests me, which when you were describing what Dr. Virchow says about public health, it sounds fundamentally revolutionary. And I was going to ask you in your 12-year span, what you felt the most fundamentally revolutionary act was that you got to do.
None. Because that wasn't my job. And when one accepts to work in that job as a government-employed public health doctor, one goes into it with the understanding that you will only be able to continue to do this job if you maintain trust of three parties at the same time. One is the public, two is the media, and three is the government. So the trust is based on again, what I think was always telling the truth, but not pushing the boundaries of the truth to my own opinions or to information that I knew in confidence, which was part of my contract to keep, within the confidence of government, etc. So it's a compromise. If you want to be a revolutionary in public health, You shouldn't be a chief medical officer of health. You should be, you should go into politics. You should be an advocate. Maybe there's other ways to do that. But you won't stay long working for government if your goal or your method of work is to embarrass government or overthrow government.
Yeah, I wasn't stressing out, but I was curious, and sorry, and I'll stop dominating. I like to push people a bit.
Yeah, I appreciate the question.
In your case, you have such a long experience and you would know so many public health issues intimately. I'm curious to hear about your personal experiences and how you navigated it. So, for example, during your tenure, I would assume that things like cladomaviar came up, which is the transmission of HIV viruses. So they would have people that they know have HIV, but it would be law enforcement. It would be the Winnipeg Police Service who would be in charge of looking into that. So you haven't spoken about any specific public health areas where you had to navigate that compromise. And I'm curious if you can just elaborate on how you did so in a specific public health issue. And then I'm done. Sorry.
Well, you know, I think every day was a day of navigating, of bringing issues forward and figuring out how to manage them in a way that respected decision-making of government and respected my role of providing my best advice to government at all times, and when asked or had the opportunity to speak to the public, to make sure that what I said was factually correct. But I don't think I'm going to give you anything more specific than that right now.
Thanks very much for a very interesting talk. Maybe expanding on the theme of revolution. I grew up on participation, so my first impression of public health was something in the very weak end of the ease, and rather individually focused. And then when I started reading in the area, I found out it's all about the social determinants of health and social justice and all these wonderful things. I wonder if you could comment on how the actual practice, the normative practice of public health lines up with the politics, and where you feel that it's the most congruent or where perhaps it's has the farthest distance.
So, if I understand your question right, you have to divide public health, I think, into two parts. So part of it is this kind of everyday business of public health practice, which is, you know, getting the vaccines out, making sure people are giving them safely, and advising doctors about things like that, making sure the public health inspectors are inspecting the restaurants and that the water testing is going, and much of it is that work, you know. The other part of it is policy and understanding and stretching the boundaries of causation of disease, because where I think public health is always at the edge is where does public health science end and where does social science begin? And I will give one example. I don't know if this will satisfy you, but it was an interesting problem that, this was actually before I was the chief medical officer of health, but I was a medical officer of health, and a group of us wanted to put into practice this conviction that poverty was an important issue for public health and public health outcomes. And so it was a time that I guess the Minister of Labor had announced that they were reviewing the minimum wage and asking for the public to have input to what the minimum wage should be. Well, a group of us, somewhat young and a bit naive medical officers of health, passionate, hearts in the right place, heads in the right place in some way, thought, well, we're going to write up a submission and bring it to the Minister of Labor, advocating for a significant increase in the minimum wage. And we got scolded on two accounts, and I think we were properly scolded on both of them. One was that, we didn't go through the channels that we have as advisors within government to give our views. But the other one, which is maybe more important, is that it's one thing for a public health doctor to observe and argue for the impact of poverty on health or of inequality of income and privilege on health. It's another thing to claim that we know how to fix the problem. And here's where I think Virchow, maybe goes further than me about what is needed to solve a problem. So we are not economists, and it is not our job to say, how much the minimum wage should go up or down, or what the effect would be of putting it up, even though it may seem obvious to us that people who earn a higher minimum wage are going to likely be less poor, etc. So I think this is a constant battle for us in public health, is because how deep in the level of causes are we entitled to go, or are we knowledgeable about? And then how far in the level of solutions, which are outside of the domain of public health practice and take us into social policy, economic policy, etc. And that's where we get into trouble, when we go beyond our expertise. So I think we can raise issues, we can raise questions, we can point to observations, we can urge solutions to these problems, but it's not our job to recommend policies to government that are outside of public health. I don't know if that answers your question.
So public health is sort of the nurse practitioner of the medical community. You can diagnose and not prescribe. Thanks, that was very interesting.
Sure.
Could you speak a bit to then, sort of following up exactly on what you were just talking about, where the onus is of the government to act on the recommendations? So if public health officials are talking about what the impacts are, and they're saying, for example, poverty has a very serious effect on health, what's the onus on the government to act on those types of recommendations and diagnoses?
Well, I'm not sure what you mean by onus, but I can tell you that from a legal requirement or from a policy requirement, none. In other words, I never expected that the expertise of the chief public health officer would trump the democratically elected decision-making of the minister or the government, who will take advice, information, suggestions from an expert. But in a democracy, rather than a meritocracy, it's up to that elected government to process the information, judge the values of the population, judge the readiness for change, judge the risk related to re-election, which again you can look at cynically, or you can say that's the measure we have of keeping governments honest. So I never expected advice to always be followed. The hardest part for me was, and this didn't just happen within the provincial government, and I think it's hard for any scientific advisor of governments today, is when governments get defensive about the transparency and accountability that goes with giving advice. In other words, I would always have been more comfortable to just say openly, including for public view, here's my advice, or here are the issues that I think need to be addressed, and then respect government to accept it or not. But governments, in my experience, and I don't just mean the provincial government, because I had quite a bit of engagement between the provincial and the federal government, they like to be on side with their advisors. So there's a pressure you either feel directly or indirectly to give advice that's going to be welcomed and accepted. And that's a very important trap, I think, not to fall into. I think I answered your question.
Hi, thanks for the presentation, really helpful. I'm actually in a health science capstone class, and this is going to fulfill my requirement for participating in an activity outside classroom. And I just had a question about, we were talking earlier about the current issues that exist, and one point I picked up, there is harm reduction versus abstinence. I'm just wondering, like, for harm reduction as a public health strategy, do you think it could further lead to situations where people who use substances and abuse drug, if harm reduction can further lead to complete abstinence of those kind of activities?
Well, if I understand your question, that is one of the theories, and I think there is some evidence for one of there's two values for harm reduction strategies. If you take, for example, the safe injection site in Vancouver, the first is to reduce the transmission of HIV and hepatitis C and to prevent overdose deaths, and that's quite measurable that those outcomes are being affected because of the ability to bring, and of course the users bring in their own drugs, but they're provided with clean equipment to inject them and support from nurses, etc., etc. The second outcome, which I think is harder to prove but is considered just as important, is to create an opportunity for people when they're ready to actually get off the drugs, and that is believed to be more likely to happen in that kind of environment than in a criminally charged environment or a more judgmental environment. And so my own personal view is that that is much more likely to occur under those circumstances, so that those who favor abstinence as an ultimate goal, I think harm reduction is often a way to get there, as well as a useful end in itself. Is that going to meet your credit for the extracurricular activity there? Yeah. Is it the quality of the event that matters, or just showing up?
It has to do with a health-related topic, so
Wait.
capsule class, so everything helps.
Thank you for coming.
Dr. Kettner,
Hello.
Deb from the MDP program. So I wasn't going to ask this question because you kind of already somewhat answered it, saying that, as a...
That means you didn't quite like my answer, wasn't full enough for you.
Well, no, I just thought I'd give a stab at it anyway. So it has to do with housing, actually, and health inequalities and social determinants of health. So housing is a big issue for First Nations community, shortage of housing and the quality of housing. What role can public health officials, chief medical officers play? And again, you mentioned about not overstepping your role,
Right.
but housing is just such an intrinsic and fundamental issue, and there's a clear issue that isn't being addressed to meet the needs, and it's quite the shortage. So what can...
Yeah. Well, it's a good question. I mean, there's lots of reasons to have improved housing. But for a public health doctor, the argument has to be the impact that it has on measurable health outcomes in order for us to play that role. And that can be everything from the impact of mold, to crowding, to lack of ventilation, to safety related to fire, et cetera, all of which are very relevant for public health doctors, public health inspectors to engage in and to point out and to even advocate for. I mean, I think I haven't used the word advocacy until this moment because it's a tricky word. Advice is when I'm asked for my input. Advocacy is giving advice when I haven't been asked for it. But bringing those facts out that's what the role is. In some cases, there's actually legal circumstances where buildings can, be by inspectors, and with the medical officer of health can be condemned and all of that when it gets to be extreme. But one always has to be careful about that because you can cause more harm than good there depending on what the alternatives are for someone living in those circumstances. So it's a long way of saying there is a role. In my view, it needs to be focused on the health impacts and the health arguments for improved housing, which are not always the most important, but they're important. Does that answer your question?
Thank you very much.
You're welcome. Thank you. Well, thank you everybody for coming out, and thank you for staying till the end, and thank you for great stimulating questions. And I hope I was able to answer them as fully as would be appropriate under the circumstances. Thank you.